Good afternoon, everyone. Welcome to this webinar on protocol standardization, key technical aspects, and clinical use of lung ultrasound for COVID-19. Today's webinar will explore the techniques, findings, and recommendations of when and how to perform lung ultrasound in the age of COVID-19. The AIUM is accredited by the ACCME. This webinar is designated for 1 AMA PRA Category 1 credit. By the conclusion of this webinar, participants will be able to list the optimal probes and settings for lung ultrasound, describe safety constraints, interpret B-lines, and discuss the benefits of lung ultrasound in the current COVID-19 pandemic. As an ACCME accredited provider, it is the AIUM's policy to ensure that the content and quality of this activity are balanced, independent, objective, and scientifically rigorous. All individuals who are in a position to control the content of an educational activity are required to complete a disclosure form. All disclosures are reviewed by the AIUM, and any conflicts of interest are resolved or managed prior to the activity. None of today's panelists have disclosures. At the conclusion of this webinar, you will be able to access the CME test located on the AIUM website. For more information on accessing the CME test and claiming credit, please refer to the handout provided in the dashboard on the right side of your screen. Participants who complete the post-test with a grade of 70% or higher will be awarded 1 CME credit. Credits for this webinar are approved for physicians, sonographers, and radiologic technologists. During today's presentation, if you have questions for the presenters, you may type them into the question box on the right side of your screen. You will be able to submit questions throughout this webinar, but the presenters will not begin answering until the end of the presentation, at which time they will answer as many questions as possible. A recording of this webinar will be available on the AIUM website. And now I'm pleased to introduce today's moderator, Dr. Richard Barr.
Thank you, Darcy. And again, I'd like to welcome everyone to this AIUM webinar on lung ultrasound and COVID-19, protocol standardization, key technical aspects, and clinical use. I am Richard Barr. I will be the moderator for this session. I am the professor of radiology at Northeastern Ohio Medical University and the editor-in-chief of Ultrasound in Medicine. We have 3 panelists, all of which are from Italy and have experience in performing lung ultrasound in their patients. The first is Libertario Demi, who is the assistant professor and head of Ultra, Department of Information Engineering and Computer Science in the University of Trento, Italy. The second is Dr. Andrea Smargiassi, who is a medical doctor in the Politico Foundation University of Gemelli in Rome. And our third is Riccardo Inchingolo, who is also a medical doctor in the same institution in Rome. We'll be asking them questions and asking their responses. We want to acknowledge the important contribution of Gino Soledadi, who is in the Diagnostic and Interventional Ultrasound Unit from Lucia, Italy. So let's start with the first question. What are the optimal probe settings for lung ultrasound and why? Dr. Demi.
Hi, Richard. Thank you for the introduction and for the question. Well, what we suggest is to use convex or linear probes. And generally speaking, linear probes are more suitable to characterize well the alterations of the pleural lines. That's because they generally provide a better resolution. Although it is not always possible to have a good image with a linear probe, and then in that case, convex probe is suggested. Any ultrasound scanner can be used, of course, but especially in these contexts, we find particularly useful to use wireless probes as the one that is visible on the right side of the slide, because they're very easily transportable, and they can also be placed in a plastic bag, so it's very easy to use them with COVID-19 patients. Then on the imaging setting, we recommend to use a single focal point modalities, no multifocusing, and then setting the focal point on the pleural line. And that's because essentially you define the imaging modality such that you're more sensible to variations at the pleural line. That is the most interesting point for the investigation in this case. Then for the mechanical index, well, keep it low. Generally speaking, start from a low MI around 0.7 and then reduce it further if possible. With possible meaning that you have a good image in front of you. Also avoid saturation phenomena as much as possible, and that can be done by controlling the gain and eventually by diminishing the MI, so diminishing the power output of the ultrasound scanner. Then generally avoid the use of cosmetic filters or specific imaging modalities such as harmonic imaging, contrast Doppler, and compounding. Here it is important to address the fact that generally speaking, echo mode ultrasound imaging is not designed for imaging an organ as the lung, where there's a lot of air, and that in fact creates problems even to standard B mode, and what you see in some cases are simply imaging artifacts. So the best option here is to keep things simple and then also achieve the highest frame rate possible. So do not use persistence, and again, no multifocusing. So you also have a good view of the dynamic of the imaging. Then store the video and not just a single frame, because again, it is important to see what happens while you're imaging an area over a few seconds, even simply because sometimes, especially the initial artifacts can be due to alterations that are very local, and with breathing, if you just take a frame, you may be missing some of these areas while scanning. So we suggest to store a video for this type of investigation. And then in the paper that is at the bottom, you can also find all these information explained in details.
Great. What should we consider in terms of safety constraints when we apply lung ultrasound?
Well, as we discussed just now, it's good to keep the MI low, and for instance, there is evidence of potential pulmonary capillary hemorrhage, and this evidence has been obtained in rats. There is a citation at the bottom from the group of Douglas Miller, and well, they looked at what is the effect of standard ultrasound imaging, including B mode, on lung tissue, in this case of rats. And what they found is that indeed there are specific thresholds related to MIs that are normally used in the diagnostic range, but then that can cause, especially when connected to long exposure times, they can cause pulmonary capillary hemorrhage. And therefore, again, we recommend to use a low MI and then limit the investigation to just few seconds. For instance, we normally do 10 seconds per area.
Great. Many people actually count the B lines. Does that really make sense?
Well, the point of just counting B line, the problem with that is that it's not going to be very reliable, not reproducible, because we know that the appearance of these B lines is strongly dependent on the frequency used during the scanning. Not to mention the dependency on different scanners, probes, and settings. So if you just rely on counting these artifacts, you have a method that will evaluate the very same patient with the very same condition differently, depending on the probe, the frequency you used, and the scanner you used, what kind of post-processing operation is that scanner implementing on board, and so on. And therefore, these semi-quantitative methods are essentially not really reliable and not reproducible. This is very important to address. In this figure here, you see the very same patient, the very same part of the lung, imaged with the same probe, the same scanner, but just changing the imaging frequency during the investigation. And you see that on the left, you cannot see any vertical artifact. Then you see plenty on the right, and this is the very same lung tissue. And again, if people are interested in reading more about this, at the bottom of the slide there are a couple of publications where more information can be found.
Great. So you're one of the developers of the Italian COVID-19 lung ultrasound database. Can you tell us how many centers are involved and how much data has been collected?
Sure. Well, first of all, ICLUS, so the Italian COVID-19 lung ultrasound project, here you can find also a link where you can find more details, is a project developed by the Department of Information Engineering and Computer Science here at the University of Trento, and then involves physicists, engineers, and clinicians. And this is very important because I think if we want to really develop the potential of ultrasound technology when applied to the lung, engineers alone cannot do it, clinicians alone cannot do it. We really need to join in a common effort. And so what we are doing within this project is essentially using model-based as well as artificial intelligence techniques for the analysis of lung ultrasound images. And we do that because we are aiming at developing an automatic diagnostic monitoring and reporting system for patients affected by COVID-19. And right now, within this project, what we have and what we can share is a specific measurement protocol that defines the acquisition points, so 14 landmarks, as well as the optimal settings and instruments to use for inspecting the lung. We also devised a 4-level scoring system to establish the severity of the patient's condition. And then we also have within the project, within ICLUS, an extensive, complete, and structured database that we are creating together with all the partners that are collaborating in the project. And then talking about the partners, we have now more than 60 institutes worldwide, including hospitals, universities, and research centers that are collaborating. As I was saying, the core institutes are the Ultrasound Lab here in Trento, the University of Trento, Department of Information Engineering and Computer Science, Gemelli Hospital, Azienda ASL Toscana Nordovest, Brescia Med, Fondazione X Policlinico San Matteo, and also collaboration with the Eindhoven University of Technology to develop the algorithms, and then many more partners from all around the world, from Africa, Europe, US, and you can see a list here of some of them. And again, on the project website, you can find more detail on that if you're interested. Yeah, again, these are more details on the database we have now. So we have more than 1,700 lung ultrasound videos from 187 patients. And the idea is that a core data set from this general database is already labeled frame-based accordingly to the 4-level scoring system described in the publication in June, and also including segmentation examples. And so this data set that contains 277 videos from 35 patients and is all labeled. The idea is to release it soon so that people can take a look at the data and also help us develop algorithms for the analysis of the data. So again, increasing the amount of institutions, scientists, clinicians collaborating on the project.
So the database will be free to anyone that wants to use it for research?
Yeah, that's the idea.
Good, and it would also be a very good educational program too, that data could be used. So what are the technical goals of the ICLS project?
Well, in few words, is really provide, on one hand, the algorithms for real-time scoring and segmentation of lung ultrasound data, which will be freely accessible through a web application where any clinicians can upload his or her videos and then get a score. So here you have, for instance, the link of the web application, and then what you would simply have to do is follow the link and then request access. And then after you have granted access, you can start to upload your data, and then you will have already the algorithms there that can score your videos. And then a clinician can also review the result of the algorithms and well, decide whether he or she agrees with the score given by the algorithms, or otherwise can change that score. So we also see if the clinicians would agree or if the algorithms fail in the evaluation, and then altogether we can build something stronger, something more functional also for the clinicians.
Great.
And this is just to show you an example of what the clinician will see. So here you see on the top, you see two different videos. On the left, you have the B mode, as a doctor would normally see it now, and then next to it on the right, there is the result of the algorithms. In this case, you see there is a map that is blue overlaid to a part of the video. Blue is score 0, so that means it's the lowest score possible, and it's essentially an horizontal artifact, what you see here, and that is generally associated with the healthy lung. Differently on the right, you see something different. And then, in fact, the algorithms, in this case, is segmenting different parts of the video and color coding these segmentations with the color that is connected to the score. Right now, it's a score 3. It's clearly appearing on the screen. And so in this way, doctors can not just see what the score is, but they can also get an idea on why the machine score in that way, and eventually also learn by themselves the patterns that are of particular interest. Then also other algorithms you see on the bottom left are now developed that do analyze quantitatively the alteration of the pleural line. So you see from left to right a delineation of the pleural line, which is marked then by a red line in the ultrasound data, and then associated to it there is a curve that shows how much the intensity, for instance, is changing in connection to this pleural line. And then you can see in presence of huge consolidations, the change of the intensity of the pleural line is significant. And this is also used to score the frame of an ultrasound video. And for this work, I want to also acknowledge the contribution from Dr. Van Sloan, Professor Ricci, Professor Pastorini, Professor Bruzzone, as well as any other scientist from that is joining this effort, in particular the students of Ultra that really worked hard at analyzing the data, and the PhD Federico Mento, which I want to acknowledge.
That's great. I think this algorithm and program that you have in collecting this database will be very helpful in us understanding not only COVID-19, but other issues when we have looking at lung programs as we go forward. So what are the benefits of lung ultrasound? Go ahead.
Yeah, indeed. I completely agree with you. We are now mainly targeting COVID because of the current situation, but this type of research was ongoing before COVID, and indeed we were studying other pathologies such as fibrosis or edema. And so this kind of effort will reveal to be particularly useful also in other contexts. I agree with that.
Great. So let's switch to more clinical questions now. So what are the benefits of lung ultrasound in the current COVID-19 pandemic?
Okay, thank you, Richard. Let's move to the clinical part. Starting with how ultrasound beam interacts with peripheral lung. When the ultrasound beam interacts with the peripheral lung, we have to take in mind that peripheral lung is an aerated parenchyma. So in the left side of the slide in this cartoon, you can see a normal disposition of peripheral space geometry. When the peripheral space geometry is normal, with normal inflated lungs and healthy lungs, the ultrasound beam is not able to assess anything, and it can be simply reflected. And when instead the ultrasound beam interacts with something different, the ultrasound the peripheral space geometry is subverted from parenchymal pathology, and you can see that the ultrasound beam in relation to its wavelength is able to see acoustic microholes and is able to be trapped in these acoustic microholes, generating a vertical artifact. On the bottom of this cartoon, you can see a three-dimensional reconstruction of an inflated lung, and in C, a collapsed lung, three-dimensional reconstruction of the surface of this lung. And you can see these acoustic microholes. Okay, next slide. Okay, from a clinical point of view, in chest ultrasonography, you can see only three kinds of images. On the left, you can see horizontal reverberating artifacts. In this case, the lung is normally inflated. In case of normally inflated lung, the ultrasound beam can be simply reflected, and you can see only horizontal reverberating artifacts, which have been called A lines, but it is a convention. On the right side of this image, you can see a consolidated lung, which in this case, when the lung is completely consolidated, the ultrasound beam is able to assess a parenchymal organ, like in case of liver, like in case of kidney. In this case, the ultrasound beam is able to show the morphology of the lung. In the center, you can see a state of the lung in which the lung is not completely consolidated, but not completely aerated. In this case, the lung we called this state of the lung hyperdense, not consolidated state. And you can see this vertical artifact. These vertical artifacts define the sonographic interstitial syndrome. The next slide. So let's take a look to the sonographic interstitial syndrome. The sonographic interstitial syndrome is characterized by these vertical artifacts. In case of pneumogenic sonographic interstitial syndrome, you can see the pleural line, which is the first hyperechoic line, horizontal line that you can see. And this sonographic interstitial syndrome can show also a white field, pulmonary field in the bottom of this slide, white pulmonary field, which has been called a white lung. Okay, So next slide. It is very important to take a look to the distribution of the findings, of pathological findings in COVID-19 viral pneumonia. These are CT scans from patients with viral pneumonia by SARS-CoV-2, and in this case, you can see that the distribution of these lesions and these findings is bilateral, is the lateral and posterior zones, and with ground glass opacities and consolidations. So the next slide, we can define a suggestive pattern in chest ultrasonography, lung ultrasonography, a suggestive pattern of COVID-19 pneumonia in a context of symptomatology compatible with. It is very important to know that lung ultrasound pattern is not completely specific for COVID-19 pneumonia, but in case of symptomatology compatible with COVID-19 pneumonia, we can check for these characteristics in lung ultrasounds which are suggestive of a case of sonographic interstitial syndrome with patchy distribution and spared areas. These findings have to be bilateral. The pleural line is altered with irregularities and in worst condition, also cobbled and coarse. Some consolidation may emerge to the pleural line, and we can see patchy bilateral white lung. So the next slide. These are examples of patchy patterns. Okay, and you can see a pleural line which seems normal, regular, linear, with horizontal artifacts, reverberating artifacts, which are indicative and suggestive of a normal healthy lung, and this pattern is very close to a condition of pleural line altered, cobbled, coarse, and a white lung associated to a white lung. This condition, in a context of symptomatology compatible with COVID-19, and this pattern, and a bilateral pattern, is very indicative of a suggestive lung ultrasonography pattern. Next. Okay, this is a worst condition in which you can see some consolidation that may emerge to the pleural line. In this case, the white lung and sonographic interstitial syndrome is associated with some consolidation. You can see in these evaluations, ultrasound evaluation, and emerge to the pleural line peripheral small consolidation, which are, if bilateral, bilateral, and in a context of symptomatology compatible with COVID-19, are very, very suggestive pattern, lung ultrasonography pattern. Okay, next.
So Dr. Demi talked about giving a score when you evaluate these as part of the ICLUS program. From a clinical standpoint, what do these different scores mean?
Okay, it is very important. For instance, if you can see a condition characterized by the pleural line with a linear aspect, regular, and the pleural line is indicated by the yellow arrow. Okay, and also in convex examination, both in convex examination and in linear probe examination. This condition is suggestive of a normal disposition of peripheral space geometry, like in case of a normal healthy lung. So this pattern, ultrasonographic pattern, corresponds to the lowest score 0. So when the peripheral space geometry starts to be altered and some acoustic traps are present on the surface of these lungs, and you can see some vertical artifacts and some little irregularities, more highlighted by linear probe, and this condition is indicative of slight alteration. This is the score 1. Score 2 is characterized by a more altered pleural line with some little consolidation and vertical artifacts and sonographic interstitial syndrome, and is indicative of more and more acoustic traps on the surface of these lungs for pathologic matters. Still to the score 3. Score 3 is characterized by white lung and consolidation that may emerge to the surface of these lungs, and this is the worst score. So score 3 is indicative of a worst condition. Next.
So your protocol requires that you do lung ultrasound over 14 different areas. And, you know, these patients are very sick and are often in an intensive care unit. And doing that is quite difficult. Why wouldn't it be sufficient to just simply scan a few areas over the anterior chest?
Good morning to everyone. Thanks, Richard, for the introduction and for the question. As I highlight in this slide, if we evaluate the patient only with the anterior ventral scan, we risk to really underestimate the lung involvement due to COVID-19. On the right part of the slide, we can see the data, the first data derived from our casuistic. And if you consider the worst score, score 2 and score 3, indicated by, in particular, score 3 by red bars, we can see that the capacity to detect these zones of the lung involvement by pathology is better if we evaluate both lateral and posterior zone and non-limited the examination to the anterior one. If we move to the next slide, please. And this information is highlighted by the increase of the agreement that we can obtain if we combine the information derived from lateral and in particular posterior evaluation with the value also superior to 8%. So this figure highlights the importance to extend the examination also to lateral and posterior zone. You pass to the next, please. In fact, this is an example of CT scan from our first cases of our casuistic. In this case, we can see that we have lung involvement, in particular in the lateral and posterior zones that are more compromised compared to ventral arterial one. So if we evaluate the patient and limit our evaluation only to the first one, to the ventral or anterior, the risk of underestimated, in particular the presence of consolidation of basal or paravertebral region is very high. The next, please.
So from a clinical standpoint, now that you've gone over some basic physics and explained why this happens and showed that you can distinguish different degrees of severity, do you think that lung ultrasound could be used as a diagnostic tool for COVID-19, not only diagnosis, but maybe following up those patients?
Yes, thanks for the question, Richard. We can summarize in this slide some advantage of lung ultrasound in order to acquire more information from diagnostic point of view. First of all, lung ultrasound, we know that it shows more sensitivity compared to chest X-ray, in particular for detecting peripheral changes of lungs. We know that the patch distribution of peripheral lesion are the commonest presentation from a computer tomography point of view. So the possibility to use lung ultrasound, in particular extending the examination to lateral and posterior, can allow us to intercept these peripheral changes, lung changes. Moreover, another important advantage, in particular for the first evaluation and the follow-up of the patient, is the possibility to perform this examination bedside as an extension of medical examination. And this can allow us to reduce timing of evaluation and also exposure to the patient. Moreover, when symptoms are suggestive of COVID-19, the combination of a suggestive lung ultrasound pattern, as described before by Andrea, can directly suggest clinicians to perform CT scan of the chest. Of course, we need to remember that lung ultrasound is a focused technique, of course, and we have to take into account the disadvantages of our technique, essentially represented by the absence of a panoramic view, of course, if compared in particular with chest X-ray for the first evaluation, and the absence of information about the central regions of the lung, and of course, also for the mediastinum. The next, please. In this slide, we would like to propose a possible approach for the focused on the use of the contribution that lung ultrasound can give to clinicians, especially in a context of emergency room when we found symptoms suggestive of COVID-19 pneumonia. An approach in which we highlight the combination, a combined approach based on the combination, of course, of information derived from lung ultrasonographic findings with other radiological technique and microbiological diagnostic tool. If we consider the right part of the slide, in case of lung ultrasonographic pattern not suggestive for a lung involvement in presence, of course, of symptoms suggestive with COVID-19, we need to keep isolation and record to the combination of microbiological tools in order to get the diagnosis. A useful combination can be swab for SARS-CoV-2 and rapid serological test with IgM, of course, if available. In case of positivity of at least one, of course, we need to hospitalization in isolation of patients, because, of course, we have a microbiological tool that confirm the diagnosis, and we can optimize the early approach to the patient, combining the data derived from arterial blood gas analysis that permit to have information about pulmonary gas exchange. If we found level then of 350 as concerned the ratio between arterial pressure of 2 to a fraction annihilated of 2, or a change of usual arterial blood gas analysis, for example, in case of chronic respiratory failure. In this case, also in presence of a lung ultrasound not suggestive, but in presence of a compromise of pulmonary gas exchange, can be useful to obtain computer tomography with or without, of course, iodine mean of contrast according to clinical condition. Instead, in case of negativity of both microbiological tools, we can obtain information always from the evaluation of pulmonary gas exchange. Also, in this case, the presence of negative microbiological tool and lung ultrasound not suggestive for COVID-19, but always in presence of symptoms suggestive with COVID-19, the presence of a compromising of pulmonary gas exchange can guide to the move to computed tomography, always plus or with or without iodine mean contrast according to the clinical context, in order to get an alternative diagnosis or computer tomography findings suggestive for viral pneumonia. Of course, in this case, can be indicated the hospitalization isolation. If we consider the left part of the slide, we have in this case lung ultrasound pattern suggestive for COVID-19. So we have the coexistence of symptoms and lung ultrasound pattern suggested. Of course, we need to maintain, to keep isolation of the patient, and this case can be very useful combined data derived, findings derived from computer tomography, in particular with the iodine mean of contrast in case of respiratory failure or signs of pulmonary gas exchange compromised, and findings derived from microbiological diagnostic tool, swab and rapid serological test with IgM, of course, if available. And so doing, we can identify few mutually exclusive ways. In case of a negativity of both tests and presence of alternative diagnosis, of course, the admission to general wards depends on clinical condition of the patient. In case of positivity for at least one of the microbiological tools before described, and computer tomography findings suspected for viral pneumonia, of course, in this case, can be considered the hospitalization in isolation of the patient.
Great. You know, one of the things I think that we're finding in COVID-19 is hematological problems with thrombosis and PEs. Is there a way that lung ultrasound can help us make that diagnosis without having to send the patient to CT?
Yes, we have we present our experience, because another important tool is the contrast enhanced ultrasonography, in which we can demonstrate, and we have a paper that has been submitted to Journal of Ultrasound in Medicine, and the study demonstrated that, at least in part, some consolidation have been caused by perfusion defects and ischemic phenomena, and not only atelectasis and inflammation. The information is derived from the timing of enhancement using the SonoView. So these evidences are very important, because it endorses the recent publication with chest CT scans addressing the ever-growing key role of thromboembolic disorders in case of COVID-19 pneumonia associated with severe respiratory failure. So chest ultrasonography can give us, can become an important diagnostic tool, also to guide and to indicate the use of iodine mean of contrast in case of chest ultrasound, in case of chest CT scan, in order to demonstrate embolic consolidation, post-embolic consolidation, or ischemic consolidations of the lung, and to also to indicate treatment with enoxaparin. Okay.
Great. So we have a bunch of references that we have collected for more information. Before we start questions from the audience, I'd like to ask just an overview from you guys of how you have found lung ultrasound to be very helpful in treating COVID-19 patients, because obviously Italy has been a country that's been hit very hard by this pandemic. So when do you use it? How do you use it? Where do you find it useful?
Did we lose everyone?
Hello?
Yeah, we hear it. So are you probably the clinicians are more suitable to start addressing
I'd like
this?
to just get a brief overview. I mean, you've given us a lot of information, but just from a very practical standpoint, how are you using this every day in clinical practice? Is everyone coming to the emergency room that has symptoms getting a lung ultrasound? Are you following patients in the intensive care unit every day with lung ultrasound, or only when there's changes?
Yes, Richard, we perfectly agree with you. We think that we can highlight different advantages of chest ultrasonography. We can obtain very, very early during the management of the patient the possibility to detect early changes of peripheral lung parenchyma with ultrasonographic extended medical examination of the patient. We can use these tools in different conditions, emergency room, intensive care unit, for example, also during a prone position of ventilated patient in a context of pediatric and obstetric setting, also in order to partially reduce, of course, the exposure of X-rays, and we can integrate the information derived from lung ultrasound with the complete evaluation that we can obtain with computer tomography, and of course microbiological tool and biochemical tool like activable gas. I don't know if Andrea would add something.
Only one thing in relation to the study with contrast enhancement ultrasonography. In this reference slide, the first listed is the paper that has been mentioned before, and it has been accepted in Journal of Ultrasound in Medicine, in which we highlight the importance to use also sonoview and sonographic mean of contrast to assess and to detect the real origin of some consolidation in patients affected by pneumonia in the case of COVID-19.
Great. So let's move on to the questions. Go ahead, Demi.
Yeah, probably it may also be interesting to add that, especially when using wireless ultrasound systems, and you could use lung ultrasound not just to help out in the diagnosis, but also to follow up the evolution of the lung, of the condition of the lung for patients that have been diagnosed positive. And if you use a wireless system, you could even do it at home and evaluate if the patient is progressing towards a worse or a better condition over time. Because differently than with CT, with ultrasound, you could do repeated measurements on the same patient, which is a very important aspect of ultrasound technology in this context.
Okay, great. So let's move on to the questions from the audience. So the first question is, if doing a quantitative score and not a qualitative assessment, please explain your reasoning or experience for why you scan back and forth between the right and left hemithorax.
Richard, can you repeat the question?
It says, if doing a quantitative score and not a qualitative assessment, please explain your reason or experience for why you scan back and forth between the right and left hemithorax.
Okay, it is very important to perform a bilateral assessment because the lesions are bilateral and monolaterality is almost an exclusion criteria sometimes in case of COVID-19 pneumonia. So the high prevalence of bilateral findings in case of COVID-19 pneumonia, because of this condition, it is very important to perform a bilateral evaluation because the chest ultrasonography pattern suggestive of COVID-19 pneumonia is based on sonographic interstitial syndrome, yes, patchy area, yes, but also bilateral findings. Okay.
Okay. Another question: how does lung ultrasound compare to clinical parameters like the need for supplemental oxygenation for diagnosis? So basically, they're asking, when you do your lung ultrasound, are you using that to decide when a patient is going to decompensate and may need additional oxygen, or put onto a respirator based on the score you're getting from the ultrasound?
So the question is why we base our algorithm, our flowchart on gas exchange alterations. Richard?
Go ahead.
The question is why we use gas exchanges and the alteration of gas exchanges.
No, I think the question is, when you do your lung ultrasound, does that help you decide on the clinical condition of the patient that they need oxygen? Does it help you in deciding which patients are going to maybe decompensate and are going to be needed to be put on a ventilator?
Okay, Richard. No, of course, the use of mechanical ventilation is essentially based on the evaluation of pulmonary gas exchange. In this case, we believe that one of the more important advantages derived from the combination of lung ultrasound finding and data finding derived from arterial blood gas analysis in case of patient that start mechanical ventilation is for obtain a basic evaluation in order to facilitate the follow-up of patients during mechanical ventilation.
Okay, another question: how do you reduce artifacts? For example, what frequency is best to detect accurate B lines?
Well, on this, there is it's hard to give a direct answer. We are still studying this. In fact, what we see is that depending on the frequency that is used, you will simply see different artifacts. And that may be explained by the fact that if you tune your frequency to essentially the size of the alteration of the lung tissue, then you will see a vertical artifact. And so we have, for instance, some results on controlled lung phantom where you clearly see that there is a connection between the properties of the bubbly layers that in the phantoms are representing the lung and the frequency at which we see a B line. In essence, what seems to emerge is that the frequency at which B line appear is informative on the extent, the physical extent, if you want, of the damage. So theoretically speaking, you will need to have a very broadband probe to sweep across frequencies and to see at which frequency you have the majority of the artifacts. And therefore, characterize the artifacts not qualitatively but quantitatively. For example, studying the frequency content of the signals that are generating these artifacts. And for that, we have some studies already ongoing, mainly on fibrotic patients, where we clearly see that by characterizing the frequency content of the B line, you may actually be able to separate different pathologies, so actually make a diagnosis and distinguish fibrosis, for instance, from other types of lung diseases. But in order to have that, you need to have a method that is dedicated to the lung. Like clinicians nowadays have a probe for the heart, they have a probe for the abdomen, and so on. Well, in the future, what we need to have is a probe and a dedicated imaging protocol, including accurate control on the properties of the transmitted signals, as well as signal processing on the received signals. And so that is dedicated to the lung. Only if we have that, then we can be sure that we have a method that is quantitative, reproducible, and accurate.
Okay. Another interesting question: does lung ultrasound reliably distinguish atelectasis from Apache pneumonia, which may not appear as a dense consolidation on CT or chest X-ray?
Okay. The chest ultrasonography is not a specific technique, so you cannot distinguish a different kind of pneumonia with the lung ultrasound, but you are able to assess consolidation and that may emerge to the pleural surface, so not consolidation in central region of the lung, consolidation that emerge in zones of the lung that are not accessible by ultrasound. The limit is this, but it is very important to have some information and this information by ultrasound, consolidations, sonographic interstitial syndrome, distribution. So this homogeneous distribution of sonographic interstitial syndrome is indicative in a context, in a symptomatological context compatible with pneumonia, with inflammatory disease, with a condition, a pneumogenic condition, and in case of not consolidation but sonographic interstitial syndrome with homogeneous distribution, with gravitational effects and gravitational distribution, and you may suspect a condition of cardiogenic pulmonary edema. So this is the role of chest ultrasonography. It is an extension of medical examination, bedside.
Okay, now here's a really good question. Can we see B lines before symptoms are occurring, and how long before they occur?
This is a very good question. Okay, very good question. Sometimes, we have we can bring an example. Some years ago, has been published a paper in which an acute respiratory distress syndrome was induced by oleic acid injection in animal models. Okay, and chest ultrasonography was able to detect the appearance of patchy sonographic interstitial syndrome before the alteration of arterial blood gas exchanges. It is a very good question. It is not demonstrable or not demonstrated in human models, but it is possible that chest ultrasound findings can precede, can anticipate some symptoms or arterial blood gas analysis exchanges and alterations.
And
Richard, on top of that,
Richard, if I can add, this is maybe probably more frequent in young previously health subjects, in particular if we base the daily evaluation of oxygen with pulse oximetry. In this case, we can observe vertical artifacts, even if we have also acceptable values of peripheral saturation of oxygen.
And then to add on the technical side, if it will turn out to be strong, the link between the frequency and the size of the alteration of the lung surface, well, and we develop a dedicated method, very high frequencies will mean very small alteration. So it may very well be that if we are able to explore the lung at these very high frequencies, that we'll be able to see even the very small alterations that now we don't intercept because the wavelengths, for instance, when you use a convex probe, are relatively low. And therefore, if we can characterize the frequency content, we can even say how advanced. So basically, we can stage the level of the alteration on the lung surface and see it beforehand. Maybe at certain frequencies, we all have these kind of artifacts.
Okay, we're running out of time, but let's do one last question. Are you using lung ultrasound for decision to prone patients in COVID-19 and recover in the prone position?
Okay, this is an ICU context. We have not this experience. We are pneumologists in ICU context, but from examples derived from acute respiratory distress syndromes, it is important to assess posterior regions of patients which are in prone position to detect and to evaluate how and if consolidations may be inflated, may be inflated using a positive pressure. So this is a real-time evaluation. You have not the necessity to transfer the patient in radiologic context in CT scan to evaluate if your positive pressure is able or was able to inflate consolidations. So it is a very good application of chest ultrasonography bedside and in real time.
Okay, here's one question that's a real quick yes or no answer. When using your scoring system, can they be used in pediatric patients as well?
Yes, Richard. Yes, one of the main advantages from clinical point of view is the possibility to use this score also in pediatric population. We have some experiences in this field, and we started to apply this kind of scoring system in our pediatric population. Can be very useful to obtain information because in this condition, in case of emergency setting, of course, the possibility to use arterial blood gas at the first evaluation is, of course, limited in case of pediatric context. So the advantage of obtain information from a technique that does not use ionizing radiation can be very useful for the first evaluation of the patient, and in particular, and also in case of identification, in particular of morphological consolidated condition, like in case of pulmonary consolidation,
it will be very useful to follow up the patient with lung ultrasonographic in order to obtain information regarding the evolution of the condition during the follow-up, always with the technique that sparing ionizing radiation.
All right, so we are running out of time.
Richard,
but before
can I just,
yeah.
I've noticed there's several questions or more than one asking about using Doppler.
Yes, so I was going to
instead
get
of
to that right
contrast.
now.
Okay, sorry.
So there were a lot of questions about contrast ultrasound. So you can use it off-label in the United States. There was questions of how to interpret the images. So when you have a consolidated area of lung and you give contrast, the bubbles go wherever there is blood flow. So you look for defects. If there's no blood flow going to an area of a consolidated lung, then it's either a pulmonary embolus or it could be an abscess. Doppler is not sensitive enough to do this. Another question that came up was elastography. So shear wave elastography uses extremely high power outputs and can damage the lung. So you should not be using shear wave elastography for looking at the lung.
Indeed. There is also detail on the publication I mentioned from Douglas Miller on the level of damage that shear wave elastography can do to lung tissue.
Yeah. So there were other questions about how to get into the database. We have some handouts that are attached to this webinar, and one of those handouts tells you how to apply and get into the database and how to use the database. So we are at a time, and Darcy is going to shut us off if I don't shut up. So
yeah, I'm
look at the
you
handout.
out.
The handouts have a lot of information that may answer some of the questions that we couldn't get to. And again, thank you all for participating in this webinar. We hope that it's been very helpful and educational in terms of how to use lung ultrasound and how it can impact treating patients with COVID-19.
There we go. You said it all. So on behalf of AIUM, thank you, everybody, participants.
Thank you, everybody. Thank you.
Everyone, remember that this is going to be on the AIUM website, so you can view this again. And if you are an AIUM member, you can get your CMEs by just reviewing it on the online and answering the questions. So again, thank you all for this. And again, we hope that as another AIUM webinar, we continue to provide excellent education on ultrasound to all our members as well as those others that are listening in. Thank you again.
Okay, have a good evening.